Hey guys, Woodruff here. Tonight we're going to do a longer lecture over acute musculoskeletal problems. So when we're talking about this section, like I said, this is the hodgepodge section. So the purpose of this longer lecture is just for those that maybe miss class, miss some things in class, aren't in my class, and wanted to watch kind of some of the things that we went over, etc. Or just for those that wanted a little bit more in-depth. If you're looking for a shorter, sweeter, simple video, I have other videos. You just go under Unit 3, under the playlist for med-surg, and you'll find simpler videos. The purpose of this is a longer lecture over acute musculoskeletal problems. So let's dig in. All right, so first let's do a review. And what we're doing a review of is one of the most important assessments when we're talking about acute musculoskeletal problems, and that's going to be my neurovascular assessment. So, for most of the disease processes that I'm talking about after, this is going to be one of the most important assessments. The reason for that is because, like it mentions here, many people that have casts, constrictive dressing, splints, other musculoskeletal problems, that puts them at risk for decreased perfusion. And neurovascular is all about perfusion. A lot of people get neurovascular mixed up and they think it's a neurological assessment, but neurovascular is actually looking at perfusion, or how well my extremities, especially my distal extremities, are getting perfused. So when you think neurovascular, think about what's going on in my fingers and in my toes. So most of the time when you look up neurovascular assessment, you're going to see either 5 Ps or 6 Ps. But over time, I have actually come up with 7 Ps and 1 C. And it's not that I created this, it's just with time. I've seen a variety of resources, and this is the most comprehensive neurovascular assessment that you can do. So, and I want to see something here. Okay, yeah, I'm going to go over in the next one. So the 7 Ps, we're going to go over them more in depth in the next slide, but there's pain, pulse, pallor, paresthesia, poikilothermia, paralysis, pressure. That's the one that usually other people don't have. And then capillary refill is the C. And when you're doing this assessment, you're always going to compare it to the non-injured side. So let's say that I had a blood clot on one side. I'd always compare that to my other extremity. If I had a fracture on one side, I'd want to compare the neurovascular on the opposite side, etc. If both are messed up, then you just want to compare to what would hopefully be normal. But yeah, so overall, most of the time when people have injuries, especially when we're talking about fractures, things like that, it's usually one side that's affected. So let's kind of dig in deeper to this. So breaking down these 7 Ps and 1 C. So first, there's pain. So when we're doing pain, one of the things that a lot of people miss with pain is that they just go up to the patient and say, hey, are you in any pain? Now, if you ask a patient that, a lot of times the answer is going to be no. For some patients, even though they are in pain. And the reason is because a lot of people have chronic pain, or, when you asked if they have pain, they're really kind of comparing it to something else versus do you have any pain at all? So I found that if I ask, hey, because I've asked patients like, hey, do you have any pain? And they're like, no, but I'm like, okay, on a scale of 0 to 10, what's your level? And they'll be like 3. But to them, that's no pain, because maybe they're used to higher numbers. So that's why I always like to encourage students to ask their patients, like, hey, what's your pain rating on a scale of 0 to 10? Along with this, we want to ask them about that pain. When did it start? How severe is it? How would you describe it? We want to know a little bit more about it. And so pain has to do with the neurovascular assessment, because if patient has no pain sometimes, or decreased sensation or something, that can obviously be an issue. But if a patient's having excruciating pain, we're going to talk about how, or excruciating or very severe pain, this can be a sign of compartment syndrome or compromise, and what that pain they're feeling is like an ischemic pain or a lack of blood flow pain. There's also pulse. And so when we're talking about a pulse, we're measuring their perfusion to their distal extremity. So we're looking for, whatever the pulse is distal from the injury. So let's say that I broke my arm, I'd be checking my radial pulses. If I broke my leg, I would want to check my dorsalis pedis or my posterior tibial pulses. So it's ever distal from the injury. we're trying to make sure that there's perfusion after the injury. Because, for example, what can happen is if I have some sort of neurovascular compromise or issue with blood flow, like let's say I broke my leg and I was worried about blood flow. If I'm not getting, like if there's an issue or maybe there's swelling in my leg, compartment syndrome, I'm going to lose flow after the injury. Like all the blood vessels around the injury are going to be affected. So I want to look after the injury and see, okay, past the injury, is there still blood flow? Pallor, this is a color, and so normal would be pink, or for some people it might even be more of a red color, not too crazy red, but like kind of like like a warm red. And what would be abnormal is pale, because like remember, all this is about blood flow, so we have to think about what shows signs that there's blood flow or not. And so when someone has that pale color, especially to like their distal extremities, it's a sign that they have some sort of compromise to their blood flow, because remember, blood is red. So when I have blood going to where it's supposed to go to, usually it brings a natural pink color to most people's skin, depending on their skin color, of course. And so then for paresthesias, what we want to do is be asking them about if they have any numbness and tingling present. So this is kind of an earlier sign when you have a neurovascular problem or a problem where your blood flow is compromised. This is going to be an earlier sign of a problem. Think of it this way: is like when let's say you're sitting down and you cross your legs and you're sitting in the same position for a while, and then your leg starts to fall asleep. How does that feel? Is that kind of like tingling, falling asleep feeling? That's a lot like what a paresthesia would feel like. They have this what do you call it? They have a similar thing when it's kind of a sign that there's decreased flow. The numbness and the tingling, the pins and needles sensation, or loss of sensation is sometimes an early sign that there is a decreased blood supply. That is telling you that there's something going on where they're not getting as much flow down there, where in the distal to their injury, etc. So you want to ask them about numbness or tingling, or can they, how's their sensation below their injury? Poikilothermia, probably the hardest one for most people to say. This is talking all about temperature. So kind of like with color, normally, when I have good blood flow, arterial blood is warm and oxygenated. And when it's going to my distal extremities and being dropped off, it should leave, when I'm having good flow, usually warm temperature to the tissues. If I put my hand on it, it should feel warm. That's usually a sign of good perfusion. Whereas if it's cold, it's a sign of poor perfusion. There's also paralysis. Now, this is a late sign. If I'm to the point where, and the same goes for pulse, if I'm to the point where I've lost a pulse, I have no pulse. And just as a reminder, sorry to go back to pulse, what's normal is usually considered 2+ is normal. I'm not as worried it's usually not going to be necessarily bounding or, anything too intense, but I'm much more worried with perfusion about it being low, like a weak pulse or no pulse, than I am if it's, a stronger pulse. Paralysis, like I was mentioning, this is a late sign. So if I'm at the point where, I have a broken limb and I can't move my foot distal to that, that's usually a very late sign of perfusion, because it starts with the early signs are usually pain and paresthesias, the numbness and tingling, and then extreme pain is a sign of poor perfusion. But if I've gotten to the point where I literally cannot move it, that's a late sign that there's no blood flow going down there. Is there swelling or edema present? This is usually going to be something you can visualize. Swelling and edema, it may not seem like a big deal, like let's say I broke my leg, but what we're going to talk about with compartment syndrome is what happens is that the swelling and edema puts pressure inward on the blood vessels that are inside around my muscles, and things like that. And from that excess swelling, it can put pressure where it decreases flow. When then you add in things like casts and other devices that further limit the amount of spread that those the muscle can swell out, etc., then the only place it has to go is push down on those blood vessels and can lead to some serious problems. So we're going to look for edema and measure that. It usually it's on like 0 is no edema, then there's like 1+, 2+, 3+, and 4+, just on how severe it is. And we usually also write whether it's pitting or not. Capillary refill, this is the 1C. This is where you touch the end of either the fingertips or the toes, and most people do it on the nail, but you can also do it on the finger, the bed of the finger. effectively what you're looking is when you push on it, it should turn white, but then within less than 3 seconds, it should turn back to pink or red, whatever color it naturally was, but to show that there's perfusion there. And so effectively, we're really going to be looking for that return of blood flow. It's just a sign that there is good blood return there in my capillaries. So all these are how I measure my neurovascular assessment a little more in depth. So just kind of keep that in mind as we're going through this. You're going to see this in a variety of disorders. And, some of these, they're going to apply more to some disorders than others, but overall, you really want to know your neurovascular assessment for this section. So let's talk about some other acute musculoskeletal problems, starting with acute low back pain. Now, this is one you really want to know, especially as a nurse. It's very common for nurses to get back pain. So for yourself, you're going to want to know this, but you're also going to, come in touch with a lot of people. Back pain is so common for many different reasons. And for many different patients you're going to have interactions with. A lot of people are going to have a history of this. So acute low back pain, it's not, you're probably going to come in touch more with chronic low back pain, but you are going to come in touch with some people that have acute low back pain. That's usually a strain or injury. So this would be if I was on the job and I lifted a patient that was too heavy and I felt like I pulled something. It usually is temporary and lasts 4 weeks or less. It's in the low back because that's where we hold most of our weight, is in that lower back area. So I mentioned being a nurse, occupational hazard, but other things are going to be obesity, physical stress to the body, emotional stress, of course, too, having a poor posture. Smoking and pregnancy can also do that. Most of the time, the patient's going to complain about pain and then also having limited flexibility or range of motion, especially in their back area. It's hard to diagnose because some of the changes are subtle, but we usually do what's called a straight leg raising test, which I'll talk about in the next slide. And then we may do a CT or MRI if we're concerned about a worse injury. So the straight leg raising test, and like it's talking about here, what you do is you raise the leg up, and then if they have pain, when there's less than 60 degrees of hip flexion, like, as the leg is lowering, if they're starting to feel a pulling or pain in their back, it's usually a sign of acute low back problems. So that's one way to kind of test for that. So kind of think of it like those hard ab exercises where you put your legs up in the air and you try to put them down. So what can we do for these patients? This is usually a temporary thing. It can become chronic. So most of what we're doing is we, focused on is we really want them to get them back to whatever ability to take care for themselves that they had before and improve their quality of life. So we're going to encourage things like weight loss can help. Strength and flexibility training is going to be key. They may need to work with physical therapy, et cetera, for some of that. Teaching them proper body mechanics so that they don't have more injuries in the future, or don't continue to injure themselves, because a lot of people just don't know how to lift or do other things like they're supposed to in their job. Even though they may have heard it, it might not have stuck. We'll talk more about that. And then, trying to maintain normal curvature and posture. Pain management is going to be key for these patients. We're going to give them medications. They may receive, if it's acute and severe pain, they may get opioids, but we use things like, NSAIDs, acetaminophen. We can also do things like muscle relaxers and things as well. And the positions that are usually most comfortable for low back pain are sleeping, and you're going to see this for back pain in general. But sleeping side lying with their knees or hips bent, with the pillows between their knees, or sleep on their back with a pillow under their knees. And you're going to see that it's that flexion in the knees that is key for these patients so that they can find comfort. And then also things like heat and cold applications can help. Some people find more comfort with heat. Some people find more comfort with cold applications. So what do you call it? Just kind of, with this, we're just looking for the position that's going to be most comfortable for these patients. And so overall, it's going to be like, really finding not only the position, but also like, what works best for these people. And a lot of times it might take them a while to find the right position, or, the right kind of application that works for them. They might have to use some trial and error. Also, we can tell them to use good lower back support chairs, like, that chairs that have the lumbar support, and chairs with armrests are going to provide better support for the back. So body mechanics. We want to teach these patients to not lean not lean over without bending their knees. So anytime they lean over, they should always be bending their knees. We should tell them to not lift things above elbow level. Because all these things are all things that are going to strain the back. They should not stand in the same position for a long time. They should never sleep on their abdomen. A lot of people that have back pain, they're like, oh, I'm going to just not sleep on my back, but it actually is a lot worse to sleep on your belly, or not to sleep on their back with their legs straight. They should bend at the knees, not at the waist if they're holding anything, and then keep it really close to their body. And this just shows some pictures of the better ways to carry things, sit, and we call it ways to pick things up. So that's acute low back pain. Let's go now into carpal tunnel. So carpal tunnel is a compression of the median nerve, and that's going to be on the wrist. And this is considered, carpal tunnel is a type of repetitive strain injury. Repetitive strain, kind of like acute low back pain, where, you're having a strain from occupation. Repetitive strain is really common in people that are in certain professions. Carpal tunnel is going to be more common in people that have kind of continuous wrist movements, or repetitive wrist movements. That's going to be people like musicians, like people that play certain instruments, like especially guitar, things like that. Carpenters that work with their hands a lot. Those that are working on computers for a good deal or part of their day. But it also can be caused by other things like tumors and masses or rheumatoid arthritis as well, which we haven't talked about yet, but we'll go into soon. So what does a client with carpal tunnel look like, and how do we diagnose it? Most patients aren't coming to the hospital for this. This is something they're more going to, talk about with their doctor outpatient. But in case you're working in a doctor's office, you may have a patient that comes in complaining of weakness, pain, numbness, and tingling in their hands. These symptoms can wake them up at night. They may also have clumsiness in performing fine hand movements. They're going to feel better. Like a lot of times what they're going to do when that numbness tingling comes up, they're just going to shake their hands out, and they're going to feel relief from that numbness and tingling, but it's not actually going to fix the problem. Or if they stop whatever they're doing, their symptoms are going to get better because it's that repetitive movement that's hurting them. But these aren't cures. Like we don't just tell them like, hey, just shake your hands, or, hey, just stop what you're doing. Because, again, there's more to this. A lot of times they might tell you this in their story when they're coming in. Diagnostic wise, to diagnose this, there's two main tests that we do for this. The first one's called Tenniel sign. And I always remember Tenniel's T for tapping, and you actually tap on the median nerve, and by tapping on it, it's going to elicit a lot of those same symptoms, like I mentioned, like the weakness, pain, numbness, tingling, etc. And so that's one sign one diagnostic we might use. The other one's going to be the Fallon sign. And this is where, kind of like in the second picture, where they have the wrist at 90 degrees flexion. And you're going to keep them there for at least 60 seconds. Usually in class, I'll have everyone do this while I'm reading this slide, so they can test themselves for carpal tunnel while we're doing this. And, it's not an official diagnostic. You don't need to run out to your doctor afterward, but if you're having symptoms, you should go talk to your doctor if it's something that's concerning or bothering you. So what can we do to make it better? So to actually truly help with this, to relieve and reduce symptoms, one of the most helpful things or most common things you're going to see done is splints. We also have other adaptive things for people that are in certain professions. Like there are so many now, like adaptive or carpal tunnel friendly keyboards, things like that, or other modifications to their workspace that can help with decreasing that repetitive movement or the pressure on that median nerve. Changing body positions. So if they have a job where they're having repetitive movement, if they can make alterations to their day-to-day or split up some of those activities, it helps. So like frequent breaks, etc. Or again, using those adaptive devices. The focus is all about relieving pressure. So they need to wear splints even at night. Physical therapy can help these patients. If it gets more severe or if their pain is bad, they may need steroid injections, or they may actually end up needing a full carpal tunnel release, which is where they release the pressure off that median nerve. But that's the most invasive option. We always try least invasive first. All right, isn't this a juicy picture? So much fun. So amputations, let's talk about it. And yes, I have seen toes like this. This is a personal picture that I took because I don't take pictures of my patients and their weird stuff and stuff like that. But this is very realistic. So if this disgusts you, that's normal. But just know there's lots of stuff like this out there that you might see in the future. So it's always good to get prepared. So amputations is not a medical condition, but it's a procedure, and it's some care of a patient that you'll definitely want to know because you're going to meet a lot of patients that have had amputations or need amputations. So the two most common reasons for amputations we've already discussed. The first is arterial vascular disease. Now I'm not talking about venous disorders or venous disease. I'm talking about arterial problems. So remember, think like PAD, peripheral artery disease, where there's a problem with flow to my toes. And that's why I would need an amputation, because I'm not getting blood flow to my toes. So therefore, I cannot, I cannot get blood flow to my tissue, so I can't get oxygen, so the tissue dies. And the other one would be diabetes, which we talked about extensively at the beginning of the semester, about how, they have decreased blood flow to their nerves and decreased blood flow in general because of all the sugar and the irritation, which can lead to ulcers that don't heal, etc. If it's a younger adult, it's usually going to be caused by trauma. We want to look for a couple things when we're doing diagnostics. We want to look for infection. So we're going to do a white blood cell count. And this is all pre-amputation if they haven't already had one. We're going to look for perfusion, like doing Doppler studies. We're going to see, and for patients that I know that have completely lost flow to their feet, they do a Doppler and they can actually map the exact point where the perfusion stops. And then if there is a wound, we may need to get a culture of it to see if there's something growing, etc. The patient could be in pain, possibly. It could be very painful for them, or because of things like diabetes or the lack of flow from PAD, they can actually have no pain. So because there's literally no flow. So the nerves don't have, they're not communicating. We also are going to maybe see signs of infection like fever. There might be drainage and stuff like that from the wound. And then we're going to do, remember, this is where that neurovascular assessment comes in. We're going to be looking for some of those 7 P's and 1 C. So color and temp changes, a weak or absent pulse, or decreased or absent sensory function. And there's more that apply there, but this is just a few to talk about. So that was kind of talking about before. Let's talk about what do we do after? So a patient goes in and has an amputation. After, they're going to need to know the signs and symptoms of infection, especially as they're taking care of their prosthesis. I had a patient not too long ago that had a below the knee amputation, and then he ended up shortly after needing an above the knee amputation on the same leg. And this is what can happen. Some patients is that we try to take as little of their leg as we can, but sometimes progressively we have to take more and more, especially if they're not keeping up with their hygiene practices, etc. So we want to teach them the signs and symptoms of infection. We want to teach them proper hygiene of their prosthesis, their residual limb, and their limb sock as well. How to care for that to prevent more infection. So if they have a prosthesis, that would be if they got a lot of people get fitted for a prosthetic foot, etc. So that's going to be a device, how do they care for it? They need to know how to clean it and care for that. The residual limb is what is left on their leg. So let's say they had a below the knee amputation. The residual limb is what's left in their leg, and just kind of watching the skin and things like that. And then the limb sock is what goes. So pretty much they have their limb and a residual limb, and then they have a sock they put over it, and then they put that sock into the prosthesis because they have to kind of put a protection between their residual limb and the prosthesis. So we want to teach them how to care for each of those things. One of the things we're going to teach them is there should be no lotions, no alcohol or powders to residual limbs. So this is a lot going to be a little bit like diabetic foot care. We do use lotion on diabetics' feet, but with these residual limbs, we do not want to put anything that can break down the skin or be caustic to the skin or cause problems. We also are going to have a priority of pain. So pain is super common in patients after amputations. They have what's called phantom limb syndrome very commonly. And this is where they're hurting in the part of their limb that's gone. So, like, for example, let's say that they had above the knee amputation. They may say that, like, my lower leg's hurting, even though they don't have a lower leg anymore. So it's really natural as a nurse to want to point out, hey, remember your leg's gone, but that's not a very therapeutic response. And that's not really helpful to that patient, because to them, like, their brain hasn't it's like the reason for it is their brain hasn't completely made the connection that limb's not there. So despite the fact that you can see it, and even they can look at their leg and see the limb's not there, sometimes it's still a struggle. Their brain's still processing it. So there are a variety of therapies that can be used. First and foremost, their pain is real. So even if you're sitting there and saying, oh man, there's no way that they're 10 out of 10 pain, their pain is real. So we treat their pain. So we always start with that. But then there's other things that we can do, like mirror therapy. And most phantom limb pain subsides after a period of time. And so other things that can help with pain management is making sure that the residual limb is properly bandaged. If it's properly wrapped, and we usually use, like, I haven't wrapped a new amputation in a long time, but we used to use what's called figure 8 wrapping. And this helps us to reduce swelling, helps with healing, which therefore helps lower the pain. And overall, then also we want to teach them after an amputation about positioning. They shouldn't sit in a chair for more than 1 hour with their hips flexed. So effectively, we don't want them to get contractures. So we don't want them to sit in one position for too long, but especially, it's really common, especially with above the knee amputations, for them to get contractures in their hip. So we don't want them to sit in a position where they're like a chair-like position, so sitting upright. You're going to see this in the hospital all the time, that there's a pillow under the extremity to decrease swelling. And I want to say that now some studies show, okay, it's okay for the first 24 hours, but in general, nursing school world, no pillows under amputations. They should not sit in the chair for more than an hour. They don't want that hip flexion for that long. And I've never seen this done in real life, but per nursing school world, we love them to be prone. So we like them to lie on their abdomen 3 to 4 times a day for 30 minutes. And that helps to prevent those hip contractures I was just talking about. So how can we prevent amputation from happening? Like I said, the most common causes are going to be PAD and diabetes. So we want to, manage chronic conditions that can affect vascular flow. So managing blood glucose, giving statins to decrease cholesterol so that we have better flow for people with like PAD, and then blood pressure control as well. Because my blood pressure is super high, it constricts those blood vessels even more, which makes it even harder to get flow. We want to teach people how to do foot care. And so especially those with diabetes, PAD, we do foot care for both of those, but teach them how to monitor their skin, look for wounds and things like that, just that daily care of their feet, and then how to properly manage hygiene to prevent infection in their feet. Education wise, they also need to know signs and symptoms of infection and general safety precautions for work and leisure activities. That would be for the younger crowd that is at risk for traumas. All right, so let's get into the main event topic that we're going to talk about in acute musculoskeletal, which is fractures. So what are they and what causes them? So fractures are a disruption or break in the bone, and they can look many different ways. You do not need to know all the different types of fractures when it comes to, like, there's green stick fractures and hairline fractures, all the different, those types of fractures. You don't need to know all those. But what you do need to know is the difference between an open and a closed fracture, which we're about to talk about. Most causes are usually from trauma. They also can have, be as a result of cancer, or it can be things like osteoporosis, which increases your risk for fracture. So like I said, you don't need to know all the different types, because as a nurse, when I'm taking care of a patient, whether they have a, like I said, like a green stick fracture, and a comminuted fracture, et cetera, is not going to really change my care for them. It might change their surgical treatment or otherwise, and the doctor is going to diagnose that. But mainly, I just want to think about what are the things I need to know about this fracture that's going to affect my nursing care. And one of the main things that's going to affect my nursing care is whether the fracture is open or closed. And when I say open or closed, what I'm talking about is the difference between it being open, like the skin is broken and the bone is exposed. So like in this picture, we have an open fracture, whereas a closed fracture, the skin remains intact. Now there may be some deformity I can see, but there's no break in the skin. There's no bone protruding out of the skin. Now this is a pretty dramatic bone protruding out of the skin, but sometimes it's not, oh, oopsie. Sometimes it's not this dramatic, sometimes it's just like, you could barely see it, but it's just a little bit. What is the patient going to complain about? It's going to hurt. They may have trouble with their limb, maybe where they can't move it, they can't maybe bear weight on it, or it may have lost function. You can maybe see an obvious break. Sometimes it's really hard when I'm turning patients at my, the trauma ICU that I work in, and I'm turning them and I can hear the grating of their bones. I hear the bone, it's broken for sure. And I'm like, oh, like, but sometimes we got to turn them to do things and things like that, or the doctor's setting the fracture, etc. And it's hard because you can kind of hear the grating and the crunching. So sometimes you can see it. Sometimes you can just look at it and like the arm or the leg is going in a direction it's not supposed to go. There's lots of swelling. It looks like it could be broken. So it just kind of depends, but you'll start to be able to see it if this is something that you do regularly. Sorry, my slides are being a little crazy. So what kind of diagnostic tests do we do for fractures? So usually, of course, we want to visualize, so we want to see that there actually is a break. So we usually do this through X-ray. The doctor will usually order multiple X-rays and stuff if a fracture is suspected. We may get a CT or MRI if we're worried about like a deeper muscle tissue, like ligament or blood vessel injury. We may do deeper, visualization through CT MRI. And then you want to think about your key labs. So you have to think about what the purpose of bone is. The bone is an important part. It's our structure. It helps keep us standing and, things like that. It's our support structure, but it also houses our blood cells, including, one of the big things is it carries around, our a lot of our blood volume. So if I have a fracture, especially if it's in, a long bone like the femur or in my hip, that's a lot of my blood supply there. And so we definitely want to keep a close eye and check an H&H or hemoglobin and hematocrit to see how their numbers are after this break, to see if there's any bleeding going on or extensive loss of blood through this injury. We also want to check fluid, electrolyte, and kidney function. Many of these patients, they're not just a fracture, they have some other trauma going on. So we definitely want to check that. But when we, when we have, a bone break, tissue injury, other things like that, there can be things like dehydration, there can be other issues where there's release of certain, chemicals or electrolytes and stuff in tissue, or loss of electrolytes through this injury. So we definitely want to keep an eye on that, especially if I'm bleeding somewhere, then I'm going to have that loss of fluid. Because the other thing I would want to look at on my, is my kidney function, because a lot of times with this, my kidney function can be affected. The other way my kidney function can be affected is that, the kidney is my trash can to get rid of extra stuff. So anytime I have an injury, I have a bunch of particles that the body, brings to this injury to help to heal the injury. And then the waste products and stuff get sent to the kidneys. And so one of the things that gets broken down when I have a fracture is usually muscle tissue, kind of getting into the next one, talking about the creatinine kinase. And, the kidneys are responsible for getting rid of CK. And so they can commonly get overwhelmed by the, all this, these particles that are getting sent to them to get broken down. So I want to check my electrolytes. I want to see how my kidneys are doing. I also, like I said, I mentioned, like anytime there's a bone injury, there's usually like a tissue injury too. And kind of think of it like when there's any sort of injury, CK, kind of like with troponin in the heart tissue. Because remember, if you remember CKMB, was a sign of heart muscle damage. CK is a sign of muscle damage somewhere. It's usually like, hey, muscle's been broken down somewhere, and it's common after a fracture, etc., for this to be the case, that there's going to be an increase in CK. It's just a result of that tissue injury. So, what's my focus as the nurse? One of my first focuses when I have a new patient with a fracture, or a patient with a new fracture, I should say, is that where it's all about alignment. So once we get into the hospital, we really want to keep things aligned. So what can I do to help as the nurse? Now, I cannot necessarily realign the bone, but I can contact the physician to come and do it if I suspect a fracture or know about a fracture, and I can maintain any devices that the doctor puts into place and then help manage, prevent complications, et cetera. So let's talk about this though. As a nurse, even though you're not going to be doing these procedures, you're going to have a lot of patients that have them, and you do need to understand what it means, and kind of what it's going to entail. Because again, when I'm telling you about these, it's not because you're going to be doing them, but it's so that you're going to be managing the patient after. So you need to understand, what are going to be some of my concerns, especially with these different devices. So when we align a broken bone, what we call it is reduction. We are reducing the injury by putting it back into place. The doctor can come and do a closed or manual reduction. And this is something that's non-surgical. It just helps prevent complications. Talk about that on another slide. Or they can go to surgery and do an open reduction. Other ways that they can, realign the bones is they can place what are called skin traction or skeletal traction, or they can have all of these done or multiple of these done. It just depends on the injury. And so pretty much we align the bones and then we immobilize. So after reduction, or if a reduction is not needed, then we focus on immobilizing through devices like casting, splinting. We can also do immobilization through internal or external fixation. In general, we can also align a broken bone through surgery in general. So let's talk about reduction. So like I said, reducing a fracture is where we're trying to align it back into place. So a closed reduction, this is the one that's non-surgical that I said a doctor can do at the bedside. And this is where they apply traction and counter traction, and they're trying to set it into place. So here's a picture of what this looks like. And, I've seen this done when I first started at my trauma hospital. There was one day they were like, hey, do you want to go down and see the ortho, resident set this person's bone? And I was like, okay, sure. Why not? I can go learn about it. And what they did is they put them under conscious sedation, like where kind of like the stuff, like kind of think of it like it's not exactly this, but it's like the laughing gas you get like when you're out for like a dental procedure where you're awake enough where they can still kind of talk to you a little bit, but you're not like with it where you're experiencing or feeling the pain of anything they're doing. So usually we do stuff like ketamine and stuff like that, or Versed, something that will, chill you out. But you won't remember it. So usually what they do is they do a procedure like this where they're trying to put it back into place. A lot of times they do this, especially with hips, when they're trying to pop them back into place. And then afterward, what they're going to do is apply traction, which we'll talk about, or they may apply like casts, splints, or braces to maintain that alignment. So pretty much, again, it's the realignment, then immobilization, usually what happens. So sometimes they get just the closed, and then we cast it, splint it, something like that, and then just immobilize it. Other times we do the closed reduction to immediately try to realign it. But then ASAP, we're going to get them to surgery, what's known as an open reduction. So an open reduction, just like the name states, it's open. So they're going in and they're reducing it or realigning it, but they're doing it internally. So this is where they're going into surgery and, actually going in and, creating some alignment and then immobilization internally. So it's obviously going to lead to better outcomes because we're getting to the problem and stuff like that, more directly. Not everyone needs an open reduction, but a lot of people that have some more serious fractures definitely going to need them. And so usually if you ever see a patient has a history of an ORIF, what that stands for is an open reduction. So they had to cut into them to fix their bone and align it in place. Then internal fixation means that they put stuff like wires, pins, screws, rods, nails, things like that to hold it into place. So that's that immobilization part that we were talking about. Sometimes they also have to do an open one because especially if it's like an open fracture, sometimes it's really dirty and they might have to go in and clean it out or debride it. Keep in mind with a closed reduction where they're just trying to align it, there is less chance of infection because we're not cutting into them. However, there is with the open reduction, it's going to facilitate, better earlier healing and ambulation usually for a lot of patients because we're really getting directly into that problem. But keep in mind with an open reduction. Since they're going to surgery, we're cutting them open. We're going to need to do things like tetanus prophylaxis, and they may need antibiotics as well. Since since we're going in surgically and stuff like that, they're going to get like pre-op intraoperative antibiotics. So here's an example. So like this is what a fracture looked like before. And obviously, while they could try to set that back into place through a closed reduction, going into surgery, look how pretty, look at this bone, it all came together. So this is, they internally reduced it or put it back into place. And then see this rod and nails that they have here is the fixation, or the way that they immobilized it. Excuse me. All right, so after a patient has a fracture repair, what is my role as the nurse? I'm going to be doing those 7 Ps and 1 C assessment very closely and regularly, making sure they get perfusion. If there's any surgical sites or drains, I'm going to be assessing the drainage and making sure they're having not too much, and kind of watching the consistency of the drainage, making sure there's no signs of infections from the drainage, the quality of it, et cetera, the color, all of that stuff. All patients with musculoskeletal problems that are acute like this, where they may have had like a loss of function, they can be at risk for complications like related to immobility. So, when you think of complications of immobility, think of things like, lung infection, like pneumonia, atelectasis. Think of things like blood clots. There's constipation, there's skin breakdown, kidney stones, lots of stuff. So, just a few things. We'll talk more about complications later, but, general things I can do to help a patient after they've had a bone repaired is to encourage them to increase their activity and get moving per the doctor's orders, of course, if they are allowed to. Make sure that they have good fluid intake. This is going to help to prevent constipation and kidney stones. And then a high fiber diet is going to help with that constipation too. To prevent atelectasis and pneumonia, incentive spirometry is super helpful. And then VTE or blood clot prophylaxis. And usually this is either, depending on where their injury is, like either through SCDs or actual anticoagulants. Most 9 out of 10 of these patients are going to be actual anticoagulants like Lovenox, heparin, et cetera. Always be aware of any activity restrictions or mobility orders. So if I have a musculoskeletal patient, one of the first things I want to do is see like, what are they allowed to do or what can they do? Because some patients have had repair, but they have different like levels of weight bearing they're allowed to put on their limbs, or what they're allowed to do with it. Or sometimes they're allowed to, get up and move around, but they have to use a special device, brace, etc. Or there's different restrictions. So, and then just know that with all these patients, especially because they've been in the bed for a while, they can have a higher chance of having orthostatic hypotension. This is also related to meds they're on and stuff like that too. So always change positions slowly with them, and then assess to see if they're dizzy before getting them up. And like I said, know their weight bearing status. So that's what I talked about, a reduction, which is the alignment. And then I started to talk a little bit about the immobilization through the fixation. Other ways that we can reduce injuries and then immobilize them are what is known as traction. And this is a pulling force to the injury. So it didn't make sense to me at first, but effectively, and these are most commonly done, they can be done in a lot of places. They can be done for like a neck fracture, they can be done for an arm fracture, but most commonly you're going to see them done for hip and leg, like femur fractures. And they help to keep things aligned, but effectively there is like a pulley that a weight is attached. You can kind of see it here. There's a weight attached here, and it's this pulley device that then goes into here on the patient. And it's effectively creating a pulling force to keep things straight or aligned. And so, this does a few things. It keeps things in alignment, or it helps with that. I told you that the number one thing I want to do with these patients is try to promote this reduction or realignment of their bones. It also helps to immobilize the joint, so there's not further injury. And then it actually, even though it doesn't look like it would, it helps to reduce pain and muscle spasm, because when there's that correct anatomical position, there's less chance of them having that pain or muscle spasm. It actually relieves a lot of it when it's in that correct position. So there's 2 types of traction. The first type is what's called skin traction, which is what you'll see up here, this boot, also known as Buck's traction. Usually we use this preoperatively. This is not necessarily used long-term, but we use this preoperatively, before they go to surgery in order to immobilize and keep the reduction of the fracture, until they can get to surgery and maybe have that open internal reduction, et cetera, and or fixation. And so it's directly on the skin. And I'll talk more about, risks associated with that here in a minute. And then there's also skeletal traction, like down here, you can see that there's actually pins going into this person's bone. And this is also what's known as balanced suspension traction. So what's my role as the nurse for this? Because remember, I'm not the one placing the traction, but I'm the one managing the traction when the doctor's not there. So if I have a patient that has skin traction, what I'm going to be focused on is skin assessment, or I'm going to be concerned about skin breakdown, because this is directly on the skin and rubbing up against the skin. So it can lead to some serious issues where they have they can have skin breakdown, ulcers, et cetera, especially if they already have injuries to their skin or tissues, maybe as a result of some trauma. So I'm going to monitor their pressure points, be looking around that device while they're in that skin traction, and monitor for skin breakdown. 1 second. On the other end, there's skeletal traction, like I mentioned, that goes directly in the bone. These have pin sites. Anytime we talk about a patient having a device that has pin sites, you want to think about concern for infection, because there's literally a route to get in the body through those pinholes, which can lead to a high risk of infection. We have pretty much like an open hole to get into the body, and we're going to be concerned that infection can get in there, especially because around these places, a lot of times there can be drainage and other things. So we want to perform pin care, which is where we usually take a Q-tip and we clean right around that pin at least once a shift. No, for both types, we need to ensure that the patient is in a correct, anatomical position. There shouldn't be twisted. There should be correct straight alignment. And we always have to keep the traction forces constant. In other words, those weights always have to stay off the floor. We have to have an order to let go of those weights, et cetera, or to take those weights off. We don't titrate them, or if the patient is, ow, I'm really hurting, we have to talk to the doctor first. We can't just take them off, or adjust them in any way. There's a certain, science to the amount of weight and stuff that they're using. And so that is up to the physician. We are there to maintain them, make sure that that the pulley force is working, and that they have not fallen to the floor. So like I mentioned, after reductions, they can sometimes, after a closed reduction, they can have, just a simple device placed. And then after a open reduction, they can also have one of these placed as well. But the next step after reduction is immobilization. We want to, keep things in place. And so we can do things like casts. And I'm sure most people watching this video have had a cast at some point in their life. We can also do different types of braces, that can be used like spinal braces, et cetera. There's splints, and immobilizers, like in this picture. This knee immobilizer keeps it straight. There's external fixators and internal fixators, which we'll talk about. But the big thing you want to think about is, okay, I'm the nurse taking care of one of these patients. What kind of assessments need to be done? And overall, you want to think about that there's a tight device around an injury where there can be swelling. And I talked about this earlier when I talked about the neurovascular system, that you want to be worried about there being constricted blood flow or pressure on the blood vessels around my muscles, which can lead to then decreased pressure to my distal tissues like my fingers and toes. So depending on where the the device is, we want to check distal. So for example, with this patient, you may be like, oh, I can't check her pulse. Oh, excuse me, can't check her pulse. But what you can check is you can check her fingertips, his or her, I can't tell, his or her fingertips for capillary refill. You can check for movement. You can feel their temperature, look for swelling, stuff like that. With this patient with the immobilizer, I would check their distal pulses, make sure that the device is not too tight, that they're still getting perfusion. When it comes to other devices, which I think I have on the next page, let's see, yeah. So something like this device, like this is, what do you call them? A Tlso Brace. So someone that has a device like this, you have to think about what parts of the body it's putting pressure on. Well, it's keeping great stabilization of my spine, which may be very important because maybe I had a spinal fracture. It's also putting compression on the patient's chest. And You have to think about when you take a breath, your chest is trying to expand up. And if it can't do that because a device is there, you might have, more shallow breathing. It's also putting pressure on the bladder. It's putting pressure on the gastrointestinal system. So there can be side effects. So the thing with all of these devices and braces and things like that are adjustable like this is you want to think about they have to be tight enough where they're providing stabilization. So patients are always going to want to loosen them, or they're going to be like, oh, this is too tight. And I always ask them, can you breathe? And if they say, yeah, then I'm like, then it's okay. Like, you have to be able to breathe, and you have to be able to, and it, not an extreme way, like, hey, can you kind of take a breath? But, as long as they can, they're still taking breaths. It's meant to be stable, like tight and stable on them, because otherwise it's not really providing that immobilization. So you're going to find it, especially with the spinal braces, people don't like them and they want them loose. They're not really helpful when they're loose. We need them to be tight, kind of that rigid immobility, especially when we're talking about like a spinal fracture, because this could be the difference between, getting paralyzed and not. So we definitely want to be super careful with these. So same with the cervical collar. These are meant to be tight and uncomfortable. They're supposed to force you to stay still. And most people don't want to stay in the same position, but we want to make sure to check for this. So like for this patient, the TLSO, of course, I would told you about like respiratory bowel bladder. I'd want to look into that. For a patient with this, I want to check their skin around the, and for all of these, you want to check the skin around the device. And you also want to make sure that, again, it's secured enough. A lot of times what happens with these is they get their chin under there, and it's not, then they got some wiggle room and they're not really correctly in. So you want to make sure that it's correctly at their jawline and not, their chin's not tucked under that collar there. With these seat collars, this is usually like when someone's in one of these, usually someone has to go in and hold the patient's neck and kind of be their collar for them when I'm changing out these pads. And usually, like when in the ICU that I work at, we change out the pads, every 24 hours. And put new pads on to make sure they stay clean and free of infection. And we clean around their neck and stuff like that too. Then we have a sling here. So with the sling, you want to make sure that it has the proper amount of slack and everything like that, but enough where it's giving good support and holding up that limb. And these are really hard to get around the gown. So just know it's going to be hell on wheels, but eventually you get the hang of it. Here's another back brace that may be used. That's not as big as the TLSO, but more of like a lumbar brace. And but we definitely same thing. You'll kind of learn. You don't need to know exactly how to operate all these devices wherever you go. They're going to have different equipment and stuff, but just know it's the same kind of stuff. You always have to think about where it's compressing and where there might be decreased flow or decreased function in because of the pressure. So if other things to consider, on top of just doing those general assessments, is we always want to elevate a casted area with a sling or a pillow. We don't want it to be in a dependent position, because if there's excess, like if I kind of like, I went on a walk with my friends not too long ago, and we're walking and we have our arms down, and we walked for like a little over an hour or so, and both of our hands got so swollen, like we were like, and it was tingling, and like we had to kind of hold them in the air. We were like, oh, from keeping our arms down in that dependent position. It was hot outside, of course, because it's Texas. But the big thing you want to keep here is we want it to be elevated to decrease swelling, because especially there's already probably swelling from the injury. We don't want to make it worse. Like I mentioned before, we're going to monitor the skin for pressure areas, especially around the devices. Encourage movement of finger and toes if it's appropriate, ordered, etc. So pretty much above and below the device, we want them, if it's depending on their injury, if it's appropriate to move, because we don't want them to get contractures. So move other joints. So let's say, like for example, that I had an arm fracture, my lower arm, then I would still want to move my fingers, try to move my shoulder if there was no fracture problem there. We talked about with spinal and body devices, not to put them too tightly, assess the respiratory status and bowel and bladder function. And then, like I mentioned, pulses, peripheral neurovascular, distal to the assessment, distal to the injury, excuse me. CAS care. So usually for CAS, what we're going to tell them to do is to apply ice and elevate above heart level for 24 to 48 hours. We're also going to tell them to avoid getting the cast wet, which can break down and cause it to not be effective. Like I mentioned before, regularly move the joints above and below the cast if it's appropriate. Now, it's really common that people get itches in their casts just because of the nature of the material, the device, the injuries and stuff like that. It's really natural. And what people always do, you see in movies all the time, people stick like a pencil or something in and scratch. Well, per nursing school world, this is a big no-no. And, what we're going to tell people to do is use a hair dryer on a cool setting if they have itching, and not to stick anything in the cast. The warning sign for a cast, and these will make more sense as we start talking about compartment syndrome, but they're going to be the warning signs are going to be increased pain despite elevating ice and medication, any sort of swelling or discoloration of the toes and the fingers, pain during movement. So like, for example, if I had a cast on my arm and like you were just passively pulling back my fingers and I was having really bad pain, that would be a sign of a problem. Burning or tingling under the cast, or sores, foul odor under the cast can all be signs of problems, whether infection or compromised tissue. So let's talk about fixators now. So I told you that, we realign or we reduce first, and then once we're realigned, then we're immobilizing. And one of the ways we more long-term immobilize is through internal or external fixators. So we talked about the internal fixators already. This is like at the top. This is an internal fixator, and these are like the pins, rods, screws, plates, etc. They go in, they do that open fixation, open reduction internal fixation. And they're going to be placing these devices to help keep things in place. There's also what are known as external fixators. Now, these are usually only used when people have really like pieces of their bone all split up and apart. But what they do is a lot of times they're going in, they do an open reduction external fixation. And what they're doing is they pretty much have these, like this down here in this picture, they have all these rods going through these pieces, kind of holding the bone together. And it just provides better stabilization when they have some really, broken fractures there. When I say broken fractures, I mean like really serious fractures, like where there's a lot of pieces. These can be used, the external fixation can be used to apply traction. If there's a bunch of fragments, like I mentioned, and then maybe when it this is a doctor's discretion, like when it's not appropriate to use a cast or other traction, this is sometimes used. So you're not going to see these all the time, these external ones, but you will see sometimes. It kind of seems like something out of a scary movie, and it's really hard to turn them and position them, but just keep in mind, a lot of times supporting them with pillows and other things, because these devices are kind of, they have all these things sticking out of them, etc. So what's my role as the nurse? Of course, there is pins that are leading into the body. So anytime there's pins, I need to do pin care. And then this is something that has an open spot where, bacteria and stuff can get in. So I'm always going to be concerned then about infection. Be monitoring for any drainage from those sites. That's sign of infection, or increased temperature, other stuff like that, redness, swelling, and stuff around those sites. So what can I do for a patient that has a fracture to help with their pain and their symptoms? I talked about some of these earlier. There's things, of course, we use things such like when I was talking about back pain, we do a lot of the same stuff. So I can use acetaminophen, I can use NSAIDs sometimes. Often we use opioids, especially when there's an acute fracture going on, because their pain's usually pretty severe. But one of the other things that you may not consider is muscle relaxers. So things like methocarbamol, or Poisothermia, I guess is how you say it. And so these are going to help to, a lot of times there's spasms in the muscles around fractures. So these help to reduce some of those spasms and can help kind of adjunctively help with pain. With these, just like with other opioids and other medications, I'm going to be worried about my blood pressure dropping, respiratory rate dropping, and it can also decrease my level of consciousness. So just be careful using these in conjunction with each other until you know how the patient reacts, because this can over sedate or snow a patient for sure. Additionally, the patient's going to need physical therapy. It's kind of one of those things like where patients really don't want to, they don't feel like they need physical therapy, or they don't really want the physical therapy, but it's something that they really is really helpful for them. like they feel really like they're like, oh my God, there's no way I can get up. It hurts too bad. But once they get up, they feel so much better. And that movement and stuff really helps with healing, but also helps them to with their pain and stuff. I know it's going to seem counterintuitive. A lot of times I find that with these patients, it helps to pre-medicate them and give them medications before they're going to be more willing to do those therapies. And then of course, repositioning or finding positions that are comfortable for them. So how can I encourage mobility? So aside from just pre-medicating and stuff like that, like I told you before, you want to know their weight bearing status. So non-weight bearing would be no weight on the extremity. Toe touch or touch down is where they can put their toe on it, but there should be no weight placed. Partial weight would be about like 25 to 50% of their weight. Weight bearing is tolerated as whatever the patient can tolerate, like however much pressure they can put down. And then total weight bearing is they can put 100% of their weight on that extremity. I mentioned physical therapy, occupational therapy. PT works more with, getting up in actual like mobility ambulation, whereas OT does a lot more of the activities of daily living, getting around, getting dressed and other stuff like that. You're going to encourage the client to move, because it's not only going to prevent complications, it's also they're going to feel better. And then they need education on how to use canes, use crutches, assistive toilet devices, and gait belt as well for safety. So there's a variety of devices they may have that you're going to teach them how to use. So what kind of complications can happen after a fracture? There's some acute complications we're going to talk about, like compartment syndrome, fat embolism. There's others that are related to, and we're going to talk about each of these. So, don't have to get too far ahead of yourself. I promise I'm going to break these down. Some of them are related to damage to the muscles and joints from immobility, like contractures, atrophy, foot drop, or blood clots. And then some are related to the original injury or from procedures being in the hospital, devices like infection. Oops. So let's first talk about the acute ones. And these are the ones you really want to pay attention to, because these are ones that, you always want to think about in test questions. Like these are the ones where we're going to be like, what are you going to do first? Or what's the most important thing? So these are things you want to look for when there's some sort of sign that there is definitely something, not good in Chinatown. So there's something no bueno with this injury. So compartment syndrome. This is what I've been talking about for a while when I talked about the neurovascular assessment, is that effectively what happens, you can kind of see in this picture, is there's this muscle tissue and then there's these blood vessels among these muscles. And what happens is when the muscle swells, they only have so much room to swell out. And then if we put a cast or other stuff on it, then it just starts swelling in because it has nowhere to expand this way. So it can only expand in, and then puts pressure on the blood vessels and the nerves. And this leads to diminished perfusion, tissue injury, and death. So it's eventually just cramps down on those blood vessels to the point where there's no flow. So why is the compartment getting bigger? Why is the swelling happening? Well, part of it, it's, I talked about it being restricted because there's dressing, splints, casts that are kind of on the outside, so it can't expand out. But also there's more contents inside. Like I said, what's really going on inside is that there's bleeding, there's inflammation, there's edema forming, and that's what's leading to that. That's what's causing that extra pressure on those vessels. You're going to see compartment syndrome more commonly in people that have long bone fractures, really extensive fractures, and crush injuries. So let's talk about the P's. I know you guys miss and love talking about your P's. Let's talk about the P's of compartment syndrome. So the P's of compartment syndrome, the problems are, these are the things you want to look out for, is pain out of proportion to injury. And what I mean by that is that if they all of a sudden start having really, I was going to say super bad, that's not really good English, but really bad pain, or it's not compared to like what they had before, like, they weren't having this kind of pain, or if they're having bad pain, but it's like comparison to the injury they have, they really shouldn't be having that bad of pain. And I'm not talking about, we can kind of get a little heartless as nurses and be like, oh, it's not that bad. But I mean, really, if all of a sudden, or, for not a good reason, they have like this really out of control pain, and like you're given meds, you elevated it, you put ice on it, and it's still not better. That's one of the early signs of compartment syndrome, is pain out of proportion to injury, or pain that's not relieved by medications, ice, or elevation. We talked about pain on passive stretch. That passive stretch is like if I had an arm injury and then you're pulling back on my finger and I start to have really bad pain. Increased pressure or swelling. So kind of like you can see here, that excess swelling there in the limb. The other early symptom is going to be the paresthesias. Remember, we talked about numbness and tingling is early, and then the later signs are going to be pallor if it gets cool, or has that, cool would be more of the poikothermia, but if it's cool, and then the pallor is the loss of color, or if it becomes pale. The complete loss of function of that limb would be the paralysis or the pulselessness. If you've lost a pulse, it's very far gone for that decreased perfusion. So early diagnosis is key. Like I said, your two top early symptoms, the ones you want to look out for on test questions, is pain that does not get better with medications or is out of proportion to the actual injury. Or again, you've tried elevating it, icing it, it's getting worse. Or if they have numbing and tingling present. Now, if I have a patient that I'm giving medications to and their pain is not getting better, I'm not going to wait a long time because this is such a serious thing. So once, like it's talking about down here, once I kind of suspect compartment syndrome, I should not elevate the extremity. I should not apply ice. So, I'm not going to because that's going to make it worse. We'll talk about that in a second. But in other words, if I've been trying these things and they're not working, I'm not going to keep pushing and trying and making it worse. So, if they have the loss of pulse or inability to move, those are the late signs, like I mentioned. So as the nurse, there's not a lot I can do for a patient with compartment syndrome because they need usually a surgical intervention or very serious medical intervention. So, one of the first things I need to do is call the doctor. I'm probably going to remove any pressure, like if they have casts that are constraining the swelling of their compartment, or any dressings. I'm usually going to remove those constrictive dressings. I'm usually going to reduce traction weight. This is one of the few times that we may remove traction weight. Usually we're going to talk to the doctor first and they're going to tell us to take it off. But we're going to try to do anything we can to relieve the pressure until the doctor can get there. We do not elevate and we do not apply ice. So, normally with swelling, I want to elevate. Like I've told you over and over and over again, elevate, 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 because it's going to decrease that swelling and help with blood flow. But with this patient, they have like complete compression of their blood vessels. So no matter how much I elevate it, it's not going to help, because even if the swelling, even if the swelling decreases, it's going to make it that much harder to have blood flow. So if I already have decreased blood flow in my arm to my hand, and then I elevate it, it's going to increase the amount of resistance that the blood flow has to overcome in order to get blood flow to my fingers. So we do not elevate, we do not apply ice once we suspect compartment syndrome. Ice is a vasoconstrictor. It's going to make that, blood flow to the distal extremity even worse. We're going to, there's usually a lot of muscle breakdown or muscle tissue breakdown or that elevated CK with this. So we're going to monitor for that rhabdomyolysis, or rhabdo for short, which is just a sign of intense muscle breakdown. The kidneys get overwhelmed. And then once the doctor gets there, they may do what this procedure is, which is what's called a fasciotomy. Effectively, they're cutting open the tissue and leaving it open to allow for expansion. It allows for acute relief of that pressure. In severe cases, amputation may be needed. A lot of students ask, usually what happens after this is they either they can close it. They usually put a patch graft over it. They'll take a graft tissue and put over that and close it up there. Now let's talk about the other acute complication that can happen that we definitely want to be looking out for on our exams. That's known as Fat Embolism Syndrome, or FES. And so what this is a syndrome where there are fat globules from fractures that are, they usually start at the fracture and then they're distributed. They tend to go to the lungs and up into the brain. And fat globules are very different within blood clots, and the fact that they're tiny, there's a bunch of them. So when I'm talking about fat embolism syndrome, it's not just one. When we have a blood clot, or a PE, it's usually one big one, etc. But this one, with the fat globules, they're little tiny ones, and they're kind of floating everywhere. They're going in those little tiny tissues and causing blockages. Fat embolism syndrome, when it happens, it's usually going to be within the first 24 to 48 hours after injury. So When you're looking at a test question, you definitely want to look at the time, like when did that patient come in, et cetera, to see if they might be at risk for this. And the two kind of common, groups of symptoms they're going to have is they're going to have respiratory manifestations or symptoms, and then neurological symptoms or manifestations. So respiratory wise, and they have respiratory ones because that's one of the places that these things get stuck. The respiratory symptoms is that they, having dyspnea or difficulty breathing. They're usually going to have a lot of anxiety, especially a lot of that's related to the inability to breathe. And so that anxiousness is pretty common. I was like, sorry, dry mouth. That's what happens with these long videos. Then they also can have chest pain as a result of, having some blockages and stuff like that, or decreased perfusion in their chest. And then they usually have signs of decreased oxygenation, like they're going to have signs of decreased, like a SpO2, PaO2 on their ABG, et cetera. So that's the respiratory symptoms. That's one of the most common places the fat embolisms hang out. They also have neurological symptoms where they might have decreased level of consciousness, or they can be more confused as well. So pretty much you have a patient who's struggling to breathe, confused, decreased level of consciousness. They can be anxious or restless as well, and have signs of poor oxygenation. You can kind of start to see in, like, if this is a picture of someone with fat embolism syndrome, where they have all these little petechiae on their chest, and also their axillary or neck area. It's just showing all those little places pretty much where those little fat emboli have clogged those little tiny vessels. Laboratory wise, we're going to find fat cells in their blood, urine, and sputum. Like I mentioned, we may look at their PaO2 on their ABG, and it'll be decreased, and they can commonly also have infiltrates on their chest x-ray. So priority interventions for this patient. We always want to try to prevent this. So one of the best ways we can prevent fat embolism syndrome is that reduction in immobilization. So we really want to minimize the movement that the patient has before we can immobilize or stabilize that fracture, which is why it's really common or dangerous, like early on when the patient first comes to the hospital. So as the nurse, once the patient has fat embolism syndrome, and this is not very common, but when it does happen, we want to provide supportive care. And the supportive care we're going to do is stuff to provide for safety, since they're having neurological symptoms. We want to protect their airway with, like make sure that they have a patent airway. A lot of these patients are going to end up in the ICU and need to be, intubated or mechanically ventilated, and support a good breathing pattern, head of bed elevated, oxygen administration, stuff like that. We're going to have all those fat particles, in the blood. And anytime there's too many particles or there's too much of something in the blood, what we like to do is dilute it. So usually they're going to get fluid replacement. This patient can have hypotension as a result of the fat embolism syndrome. And then encourage good respiratory, function with coughing and deep breathing. Overall, let me see, I think that's the last one, yeah. Overall, what you want to consider here is that fat embolism syndrome, it's very different. People mix this up with blood clots. I didn't really talk about the why here. So fat embolism, there's a couple theories about why fat embolism occurs. There's a theory that it's like a result of the actual mechanical injury itself, releases fat globules into the blood, like the mechanical injury of the fracture itself. And there's other theories that it has to do with chemicals that are released in the inflammatory and fracture process. But regardless of it, you can't give anticoagulations because they're not going to do anything for fat. There's no anti-fat drug or fat breakdown drug. And these are little particles and they're everywhere. And so, as a result of that, all we can really do is support them. So we need to support their support their airway and their breathing for their respiratory symptoms, and then provide for safety and good mentation for their confusion, decreased level of consciousness. And then hopefully, patients can recover from this. It just depends on how severe or, where the fat globules go and if it's caught early enough and started to treat. And then, like I said, the other thing we'll do is just dilute those fat particles and treat their hemodynamics or their blood pressure, heart rate, all that stuff. Replacing that fluids can definitely help to dilute some of that and support their blood pressure. So other complications, we talked about some that can happen as a result of immobility and stuff like that. So when someone's been like in a cast or really predominantly use one of their limbs more than the other, they can have what's called atrophy, like what's seen in this picture. They can have contractures, which is where like when the a body part gets stuck in the same position for a while, it can kind of get like permanently stuck. So this is an example of a contracture. There's what's called foot drop, and you can kind of see that here in this picture where the foot is literally kind of in a pointed position, and this is a result, it's something you don't really think about, but when we're walking around, we have shoes on, it helps to keep our feet in a natural anatomical position. But if I'm laying in bed all day and I don't have anything kind of keeping my foot in a normal anatomical position, we can end up, and also because sometimes of neurological issues, we can have what's called foot drop. So we use what these are called orthotic boots. You can see them, that you might hear them called POTUS boots, things like that. And these are used in the hospital to help to keep that normal anatomical position. Another complication they can have is spasms, like I mentioned before. There's also blood clots. So these are going to be high risk, especially for people that have femur fractures or hip fractures, just because of the nature of the injury and what, bones contain. They're higher risk, like any sort of patient that has like a bone disorder, fractures, those kind of surgeries, you're going to see that they're going to be anticoagulant up. They do not mess around because they are super high risk. Excuse me. They also, have limited mobility. So on top of the fact that just from the injury alone, they're at higher risk, they also have limited mobility, which increases their risk for blood clots. So they're either gonna, they're usually gonna be on anticoagulant, like I mentioned, heparin or Lovenox, and they're also gonna usually have SCDs, TED hose, foot pumps, those exercises that we do where we tell them to pump their feet and stuff like that. We're going to be using multiple resources here. Infection. So we talked about, like, as a nurse, I need to know the difference between open and closed, and patients are going to be at higher risk for infection with open fractures versus closed fractures. And they're going to, if they have an open fracture, they're going to need like really aggressive surgical debridement. They may need antibiotic irrigation or beads. And we talked about tetanus prophylaxis for open fractures. Now, not everyone with a fracture needs tetanus prophylaxis. If they have an open fracture, they do. And they only, of course, it's all based on the last time they got their tetanus and stuff like that. We'll get into that when we get into neurological, and kind of what the, the qualifications to get, the Tdap booster and stuff like that are. And then, like I said, perioperative antibiotics. So how can we prevent fractures? We can prevent fractures by regularly using seat belts. Of course, safety things like driving within the speed limit, not texting and driving or distracted driving, or driving under the influence of drugs and alcohol. If they're going to exercise, doing a warm up before. Protective equipment for sports activities, safety equipment at work, helmets. I can't tell you how many very severe, like head, face, and other such injuries that involve a patient not wearing a helmet. Safe environment to prevent falls, and calcium and vitamin D diet for patients, and overall to support bone health. So I believe this is the last thing we're going to talk about. We talked about fractures in general, but I do want to touch specifically on hip fractures. So 95% of hip fractures are result of a fall, like in older adults. What you're going to notice specifically for this type of fracture is the patient can have what's called external rotation, or it's rotated out of their limb, like you can see here with this foot. They can have spasm. You can see shortening. Look at this leg, how much longer it is than this leg, because what's happening is when it pops out of that ball socket, it pops out and goes above that ball socket, which leads to a shortening of that extremity, and they can have severe pain and tenderness around the site. So we usually, with these patients, like I said, they're more common. We're going to use traction to immobilize them. Really want to limit their movement until it is officially, reduced, and do early surgical intervention. So you can kind of see this ball socket, they can do different. There's a partial hip, total hip, or hip compression screw that can be done. Those are just a few. There's many, many more, I'm sure. So what can I do as the nurse to help this client? Pain medication. We really want to, you know, stay ahead of that. And like I said, they can have spasms. They may need some muscle relaxers as well. We want to prevent dislocation. So you can kind of see what this patient, they have this wedge in between their legs. And it's not to keep their legs spread apart, it's to prevent them from crossing their legs. They're usually going to need physical and occupational therapy. They're doing a lot of new things now with hips. You know, my father-in-law had his hip replaced not too long ago, and I was really surprised when they sent him home and they're like, "Oh, he doesn't need physical therapy, just get up and walk." And I was like, "What? No way!" But a lot of hips, they still need physical therapy. It just depends on the patient, depends on the approach they use, the physician, etc. Muscle strengthening can be done through like swimming, stationary cycling, things like that. We don't want anything high impact, of course. They may need assistive or adaptive devices, you know, especially if they're having severe pain or, you know, loss of injury. When they're at the hospital, we're going to use what's called a trapeze bar, and it looks like a triangle, and they're going to use that to pull themselves up and kind of, you know, get better mobility within their bed and stay mobile in their bed when they're not up and out of into the chair or whatever. Neurovascular wise, we want to always keep a close eye on those distal extremities on their feet to make sure that they are getting the perfusion they need. And then, like I mentioned, especially with any long bone or hip fractures, high risk for blood clots. So here's some different devices. I want to talk about different precautions, but generally we don't want these people like bending over at their hip because it can pop it out. So they have these cool things. I mean, maybe even if you don't have a hip replacement, but you're just really lazy or really think it looks cool, you might want one of these. So they have these cool little things to put your sock on where you don't have to bend over. They have these elevated toilet seats, which are going to be super handy. There's great devices to get in and out of the shower. And you can see like this woman using this kind of special device to get her leg in and out of the shower to move it without bending or pulling it up too high or reaching down for it. So here's some other things. There's some grabbers. Now, I'm going to tell you, ladies and gents, you got to watch out for people with these grabbers. They will grab just about anything. So you need to get that older man or woman that got their grabbers, they'll pinch you. And I'm not even saying like in a sexual way. Like sometimes it's just like, sometimes they're just mean or sometimes they're trying to be funny, but they'll just grasp you with these things. So be careful. Make sure you trust anyone you give one of these pinchers or grabbers to, because, you know, no matter what, you know, they're coming for blood sometimes. So you got to be careful with some of these adaptive devices. So I told you there was special education for these patients. So we really want to prevent dislocation. And this shows you a picture. So you see how the prosthetic went above this ball joint. So in order to prevent that, we want them to, you know, avoid no more that, like, we don't want them being at 90 degrees flexion or more. We don't want them to cross their legs or have adduction across the midline or any internal rotation, because that can also lead to the popping out of their hip. They need to usually follow this for about 6 weeks. No crossing their legs. So it's not forever. No crossing their legs, no elevated toilet seat. They need to place a chair inside the shower or tub in order to do those. They put that pillow or that wedge in between their legs to prevent the crossing. You want to keep their hip in a neutral, straight position. Notify the surgeon if they notice any deformity, and no tub baths or driving. But you can see here, you know, obviously they're going to have some symptoms. So this is going to cause them to have a shortening of their limbs. That's going to be one of those key, like, hey, you need to report this. Sudden severe pain, because usually it's going to be painful for it to pop in this position. They're going to have an external rotation of their limb because of this popping out of place. And because you can imagine this is going to cause like a lump in their buttocks. So those are kind of the key symptoms to report for hip fracture dislocation. All right, believe it or not, I survived, and it's perfect timing because I ran out of water and I am thirsty. So I'm going to stop talking for tonight. I hope this rambling, babbling that I tend to do was helpful. I'll see you for the next one.